was nervous too. It was just me. Everyone smile real quick. All right. So thank you, first of all, Nate and Health Bar for having me. Really honored to be here and speaking to you all, who I can see in the audience. We heard some great things earlier today. I loved it. Team, performance medicine, lifestyle change. You're going to hear from some far more talented people than me later today as well. And this talk is none of those things. So this talk is about finance, the other F word. And we're going to talk about what's going on in healthcare spending today. Why is it that we spend $5.3 trillion and feel like everybody's talking about how much money they're losing and where's the money all go and why is care getting worse and all these. It's going to be like super uplifting. It's going to be great. We're going to have a good time. Okay, so let's jump in. So this is what we're all told about healthcare from a numbers perspective often enough. And these numbers are true, but they're only part of the story. Again, we're spending $5.3 trillion annually. It's growing about 7% a year. It's going to be higher next year. It's going to be higher the year after that. People are working really hard, trying to make meaningful change, doing all the right things, and yet all we hear is the hospitals are losing money. They have no margin. They can't pay clinicians enough. Insurance companies are losing money, right? They don't make anything. Yeah, they have, United Healthcare makes $440 or so billion in revenue, but their margin's only like 2%. So it's not, it's tough business, right? They're not making that much money. Physician reimbursements down. We're all paying more for healthcare. Like, what's going on here? This can't be the whole story. And as the bearer of bad news, it's not the whole story. And we're going to talk about why that is and what we're seeing. So this is what we're going to be talking about today. These sort of 4 points, a little bit about hospital finance, a little bit about the vertical integration in the insurance company world, all of our favorite insurance companies, United Healthcare, Aetna, all those guys, and the cost shift, and really about system design. Because fundamentally what we're dealing with here is a system, healthcare system, which operates in broader macro systems. We have for-profit, publicly traded companies. We have nonprofit, or we don't have to pay taxes, companies. But there are other things operating here that really make it imperative for them, not to say that they're all innocent in all this, but for them, they're operating in these systems that they necessarily need to be financially driven in a lot of ways. So, and we're all seeing these slides for the first time, by the way, so just bear with me. So I'm going to start with the hospital side. So this is how hospitals get paid, sort of generally speaking. There's 4 big buckets, I suppose. There's commercial insurance, there's Medicare, there's Medicaid, and there's self-pay. Self-pay is pretty small. If you look at hospitals and sort of segment them and say large health systems on one side, rural hospitals on the other side, and we know we have a rural hospital crisis. Rural hospitals are always about to close, or they are closing. And we always want to say, well, it's Medicare's fault, right? And it's Medicaid's fault. They're underpaying the hospital. You make 83 cents on the dollar for Medicare. It's usually much worse for Medicaid. But what's interesting is when you look at the data and you start to look at the commercial rates too, it's actually the commercial insurers that are underpaying rural hospitals the most. They're actually about breaking even on Medicare, making a little less and losing money on Medicaid, but losing the most amount of money on commercial plans. Because commercial plans don't have any incentive to pay a rural hospital that has 25 beds or 48 beds a high commercial rate. They're not getting 250% of Medicare. But the hospitals that are doing well financially, they're making, and if you look at the margin, it makes sense, but the higher the commercial rates, the higher the margin of the hospital. And it's not that these hospitals are necessarily delivering better care. It's not that they're necessarily so much more advanced. It's not really any of those things. It's really a game of leverage and consolidation. Because when you're an insurance company and you have a market like New Mexico, for example, and there is one major health system in the market, you don't want to exit and lose 100,000 covered lives on your plan. So you have to go and play ball with the insurance company that has all the leverage and has all the power. So you get these forces that are kind of competing with one another, although are they? That's a little foreshadowing. And like what actually is going on in that relationship. So that's just sort of the high level. How's the hospital getting paid? What's important? They want consolidation and leverage to drive up their commercial rates. And hospitals, by the way, are the biggest cost pool. So this is the part about, well, is that all there is to the story? Okay, they're still telling me they're losing all of this money, right? But if we look at the big buckets of where healthcare spend goes, hospitals, from a revenue perspective, represent $1.6 trillion of the $5.3 trillion in spend. I also mentioned earlier that they're mostly nonprofit, right? HCA, Tenet, CHS, some of those notwithstanding, most are nonprofit, tax exempt. It doesn't mean that they don't have investors. And it's a big thing that I think people don't talk that much about or discuss often enough. There may not be stockholders, but most of these hospitals have bondholders. They issue municipal revenue bonds so that they can build new wings of their hospital, new lobbies, so they can invest and buy another hospital down the road, a physician clinic, right? Because what's their goal? Consolidation and leverage. Yeah, they're going to invest and they're going to buy like great equipment and machinery so they can compete with BAMF, who's way better than them. But they also are, again, playing this leverage game. And when you have bondholders, you still have to create a return for them. They're not going to buy the bond if you're not doing financially well. And if we look at Moody's or Standard & Poor's, what do they care about when they're rating a bond? Do they mention patient outcomes? Do they mention high performance medicine? And if your team is completely, burned out and morally injured and all these things? No. Revenue growth, market power, cash, days cash on hand. These are the things that they care about. These are the things that the investors care about. We have created a system where these for good, public good, nonprofit organizations have to operate like a financial institution first, that happen to provide patient care second. And if we look at some of the numbers, that's what we hear, right? 1% operating margin. Meanwhile, on average, it's over 6% in operating cash flow. Hundreds of days of cash on hand. They raise debt, sure, but way more cash to debt. These are the numbers that once you really start to dig in, you realize, hang on a second, there's more than this. We lost X amount of money. When I started writing on LinkedIn, one thing that, a post that sort of took off one time was that Ascension 2-3 years ago or something, their operating margin, their operating income, or net income rather, was negative $1.8 billion. And that was all the headlines. That's what they said, that's what Becker said, that's what everyone said. Well, if you just went 2 financial statements down and you saw that their cash from operations was $1.7 billion. So there's so much more happening behind the scenes with cash, with investments, with all these different things. Again, we get revenue from patients, from commercial, from et cetera. We pay all our clinicians, we have supplies, and then we make this sort of tiny little piece of operating income or net income. There's so much more happening in the background with these groups. Here's a little case study. Who's heard of Kaiser? Anybody? Nobody? They're a hospital, guys. They're in California. No big deal. So these are some 2025 numbers. Kaiser, by the way, I find this interesting. Who loves Disney World as much as Eric Ross loves Disney World? Anybody? No, okay. Kaiser is larger on a revenue basis than Walt Disney World is. This is a nonprofit, California-based hospital that's bigger than Disney. This is a Fortune 50 company. A lot of the hospitals and health systems across the United States are at least Fortune 500 companies. We just don't count them as such because they're nonprofit and they're tax exempt. So we don't look at them in the same way that we look at, HCA, or we look at, United Healthcare or something like that. But there's a big component here to the rising healthcare costs and where these health systems sit. So anyways, if we look at Kaiser, for example, again, we see that operating margin, thin operating margin. But look at what they're holding in cash and investments. Look at what their net worth is on their balance sheet, their investment income versus their operating income. And from their own CFO saying that they use and leverage, which honestly, wouldn't you? Their balance sheet, because their operations have become sort of a, necessary means to fuel this financial behemoth that they've built. And a lot of health systems, again, sort of have to operate this way because we have asked them to serve the public in such a way, but then also contend with the insurance companies who are controlling a large percentage of their dollars that are for-profit, publicly traded companies, and they're trying to grow and invest, and they have to create this market leverage, or else they're going to be the rural hospital that has, a drag from a low commercial rate that's not going to let them operate, and they just get bigger and bigger and bigger. And so what does that mean, though, too? Because I've been talking about it a little bit. There's insurance companies, right? What's the other side of the coin of this whole equation look like against Kaiser, against, anybody, Trinity, all these big health systems? We know the hospitals want higher rates, but presumably, you would think, well, insurance companies want to lower costs, right? Who thinks insurance companies want to lower costs, other than for their Medicare Advantage population? Nobody? Somebody, just raise your hand. Come on, I need one person. Okay, fine. Who has heard of the medical loss ratio, or the MLR? 6.5 people. So the medical loss ratio came about during the ACA. It basically says that an insurance company can't make more than has to spend 85% of its premiums on medical care delivery. It sounds really wonderful, right? But when you're a publicly traded for-profit company and they say to you, you can never make more than 15%, what are you going to do? What's your lever? Price. You raise your revenue, and you don't have to change anything at all in between. Or, as we will talk about, what else can you do? You own the middle. You start buying your operating expenses. So that instead of saying, oh, I only made 15%, well, yeah, on paper, because I overpay my own doctors and spend on medical care by 10%, 12%, 18%, and then that 18% just goes straight back into my pocket, into my coffers. So again, we have all these great intentions in healthcare. We want to do the right things, have the legislation, say what you will. But what happens, though, is, again, when you have this broader, big system operating and governing these subsystems of healthcare, what are they supposed to do? We're asking a for-profit organization not to have a return to shareholders who can literally sue the company if they're not working in their own best interest, which is to maximize their returns. So we start to see some of these dynamics. I told you this was going to be uplifting. So we start to see some of these dynamics that really are creating the pressures in the system and why we're spending $5.3 trillion, but feel like everybody's broke and we're all losing money and this is not working. So again, hospitals want their increased commercial rate, and that's why I said a little foreshadowing, because the hospitals want it, and the insurance companies have to sort of pretend like they don't want to pay more, right? And maybe in a crunch time, maybe if their MLR is a little high or whatever, they don't really want to. But when they start paying more and their MLR starts to compress, what do? Whose premium's going up this year? Anybody? What are the employers in the house, right? 6%, 12% in some markets, 20% in other markets. They just pass the cost along. Because the insurance companies don't actually pay for anything. They're just processors of our money. So this is where they sit. Insurers sit at the top of the funnel. These are the three big levers that they work off of from the most part, which I talked about the first one, increased revenue. They're capped. Their profit it's like game over, right? They can't make any more. The only way to do it is to raise premiums. And they pass along those costs, especially with most of the market being employer market. They have Medicare and they have commercial. So they want increased revenue. Vertical integration is the other one. We're going to get into a little bit there. United Healthcare is the poster child. Is that a positive term? Or I don't know. But they do it better than anyone else. Let's just call a spade a spade. And then the balance sheet. So something, one of Warren Buffett, I think, called it the eighth wonder of the world or the ninth wonder of the world is float. So, or maybe he said it was compound interest, but I'm stealing it for float. And basically, the insurance company, they take all of our premiums, they throw it on their balance sheet as a liability, right? They owe that money, but they also have the money that they are going to pay out. Well, what are they going to do with it? They invest it. They buy medical practices. They vertically integrate more. They put it into the market to generate returns. And when you have your money, my money, everybody's money, that you owe, right? They're going to pay it out eventually. They have actuaries that work on all this stuff, but it's going and doing work for them. Well, they want it sitting there as long as they can, right? Who has issues with prior auth delays? Who has issues with denials? Who's a clinician in here who's independent, who's like, I've been waiting for 6 months for this claim to get paid. What's going on? What's the update? And you get the turnaround time is 45 to 60 days. Well, every day that cash sits in an investment vehicle, every day that they can use it to buy something else is a good day for them. So the business model is raise premiums, let the hospitals kind of take the fall for it, right? We want the revenue to go up. We can vertically integrate because we can overpay ourselves and we can keep more of that medical loss ratio. And then let's leverage our balance sheet because we have all these people who are paying us all these premium dollars. I know I got to pay for it, but like they didn't say I had to pay for it today. Maybe I'll pay for it in 5 months. So this is the closed loop. Again, we had Kaiser as the case study for the hospitals. What would a talk about insurance companies be without mentioning United Healthcare? So this is their loop. We have, they collect the premium dollars like I mentioned. They pay themselves in Optum. They employ somewhere between 90,000 and 100,000 physicians to date. That doesn't include all the staff. That doesn't include all of the advanced care practitioners. That doesn't include everybody else. That's just physicians. They're the largest single employer of physicians in the country. They have Optum RX, PBM. Lucy RX in the back is trying to take them out. I think they're going to do a good job. Strong Kit Kat game too, so I do recommend it. And then you have Optum Insight, so they're processing claims. So United Healthcare has vertically integrated the entire healthcare delivery system to the tune of $165 billion in intercompany eliminations. So that is the amount of money that they basically have paid themselves in 1 year and just got to basically keep the spread that they've been paying themselves. So this is $165 billion of basically fake medical loss ratio that they just have paid their own clinicians. And so this is the other competing force. It's really a big driver of the healthcare cost. And then you can see there the $39 billion of float. Again, this is just for United Healthcare. The $1.125 trillion, that's 3 insurance companies. 3. It starts to become really easy to see, hang on a second, $5.3 trillion, that's a ton of money. I don't even know how many zeros that is. It's too many to write. That's why we write a T at the end of it. And where all that money starts to get locked up and where all that money is going. So we have these dynamics, hospitals, insurance companies, everyone just wants to make more money. Who pays for it all at the end of the day? That guy pays for it. He had his hand up. We do. Who pays for Medicare? Tax dollars. Who pays for Medicaid? Tax dollars. Who pays your premium? Well, you do and your employer does. What happens when your employer has to spend $20,000 a year on your premiums. Well, that's before a claim is filed. It's before you actually go to the doctor. It's before anything happens. Who here has a high deductible health plan? Anybody? Yeah. Most people. That's the cost shift that is happening. So the insurance companies they're at the top of the funnel. The hospitals are trying to make it, but they also have these incentives to grow and gain leverage and drive price and all those different things. And who's footing the bill for all of it? It's more and more cost shifting to employers' plans, to individual patients who are struggling and having issues. So where it all ends up, that's why this room is so exciting and so spectacular, because everybody here obviously is doing all the hard work, is doing amazing and incredible things to change the healthcare system. And while these numbers are frustrating and staggering, I have one more that's really gonna piss you off after this one too. This is where the opportunity is. Because we're talking about, trillions of, you can't even count to a trillion in your lifetime. That's a weird thing to think, but it would take too long to count that high if you just spent all day counting. And we're spending $5.3 trillion annually, every year, on healthcare, and it's gonna go up. But that's what the opportunity is, because we're right now on an upward spiral in cost. Hospitals need more money, insurance companies want more money, everybody's sort of like, we're in the middle, paying both, not really getting a lot, but then the health bars of the world, the Lucy RXs of the world, the BAMF Health of the world, all of these organizations are existing and coming into the market. The guys from JP Morgan are investing in employer-sponsored plan solutions, things like that, to really start to look at these numbers and say, how do we do this differently? How do we do this better? What are the options? Because at the end of the day, what I take some solace in, some hope in is rooms like this, first of all, but also looking at direct primary care, at self-funded health plans who have nurse navigators who are taking patients and helping them navigate and steer to low-cost centers with high, excellent care, because there's an idea out there that while we look at all these numbers and they are like jarring, that healthcare might actually already be fixed, because we do know what to do. We do know where you can get the best care. We do know that you need, to focus on the right social determinants of health. We do know that lifting more people up help the entire whole of healthcare. We do know where the centers of excellence are, where the lower costs of care are. A doctor is generating, on average, like an orthopedic doctor, $6 million for a hospital and getting paid a great salary, right? $400,000, $500,000. But then in private practice, they're generating, maybe around $2.5 million. So $6 million in the hospital, $2 million outside of the hospital. We know where people should be, but again, we've done it this way for so long. We have these forces in the market. Now hospitals are seeing it, leveraging it, consolidating, building up their market power so that they can go and negotiate, so they can please their bondholders, so they can do all the things that they're working to do. But we already know where to go and short circuit this. And so that's what's incredibly optimistic while I share with you all these terrible things about healthcare. This is where the opportunity is, and these rooms are where the change makes this kind of thing happen. So I have no idea how I'm doing on time, but I do have one more, the piss off number that I'm gonna show you all. So we have these two numbers, but if we today had every clinician in America work for free, we would still be the most expensive healthcare system in the world by $2,812 per person. So if that's not a signal that, as Nate said earlier today, that the healthcare system is working just as it was designed, that's a pretty big signal. Because clinicians are out there, our doctors, our nurses, our PAs, our respiratory therapists, everybody's out there doing the work, actually delivering care. They're the value driver in healthcare. And yet if we pay them nothing, we're still the most expensive healthcare system in the world. So that's depressing, and I'm sorry. But again, it is the opportunity. because it's not our clinical system that's broken. We have amazing clinicians, we have great technology, we have amazing sites of care. It's how do we create a different kind of system? How do we steer people the right direction? How do we leverage what we already have, what we know what works? How do we replicate it across markets so that people have access to these great and amazing care modalities and settings? So with that, I think I hit my KPI today, which was actually like maximum one person asleep per table. So I think I got it. Thank you guys so much for your time, and thank you for having me.